Welcome, doctors. Okay, picture this classic AAO scenario. You've got a 48-year-old hyperopic patient sitting in your chair, and they are absolutely convinced their near vision just suddenly failed overnight. Now, do you just kind of guess their near-ad prescription based on their age, or do you know the precise optical physics behind it? Today, we are taking a masterclass journey through the aging eye in this explainer. We're going to focus heavily on presbyopia, accommodation, and honestly, the high-yield optics you just have to master. We aren't going to sit here and just memorize random facts, all right? We are going to build a rock-solid mental model so you truly understand the anatomy, the physics, and the clinical reasoning behind all of this. So before we really get into the weeds, let's do a Socratic active recall moment. I want you to pause for a second and just think about this classic board question. What single vision reading prescription should be given to a 4-diopter hyperope with a 3-diopter accommodative reserve versus a 4-diopter myope with a 4-diopter accommodative reserve? Seriously, lock in your answer right now. No cheating. We're going to break down the exact clinical algorithm to solve this in just a few minutes, but I want you thinking about it first. All right, here is our roadmap for today's session. First, Duane's curve and accommodation. Second, presbyopia correction rules. Third, bridging the intermediate gap. Fourth, image jump and Prentice's rule. Fifth, anisometropia and convergence, and we'll wrap it up with some rapid-fire board pearls. Let's dive right in. Section 1, Duane's curve and accommodation. Okay, so let's talk normal physiology. I want you to burn this number into your brain. 14. On average, a young child has a maximum of about 14 diopters of accommodative amplitude. This is their absolute physiologic peak. But right around age 8, the crystalline lens slowly starts to lose its inherent elasticity. And this massive amplitude, it begins its long, predictable drop. So how fast does it drop? The rate of loss is exactly 1 diopter every 4 years. Now, if you do the math from age 8 to age 40, that's 32 years, right? Which means a total loss of 8 diopters. That leaves the patient with exactly 6 diopters of accommodative reserve right at age 40. This is an absolute must-know number for your written boards. Why? Because it's exactly when patients typically start noticing those very first, super annoying symptoms of presbyopia. Now, from age 40 to 48, the pathophysiology really accelerates. The loss jumps to 1.5 diopters every 4 years. This leaves them with only 3 diopters of accommodation by age 48. At this point, their accommodative reserves are literally too low to sustain near vision without clinical help. And you know, patients will come in complaining that their near vision failed abruptly on their 45th birthday, but actually scratch that. It was a gradual biological decline that finally just crossed their symptomatic threshold. By age 72, that reserve hits 0. Moving right along to Section 2, Presbyopia Correction Rules. Let's see how we fix this. All right, so here is the crucial point in solving that hyperope versus myopo board question from earlier. You just follow this exact 3-step algorithmic rule of thumb. Step 1, determine their distance prescription. Step 2, add the default near demand. Now, standard optics assumes a 40 centimeter reading distance, which requires a plus 2.5 diopter add. Step 3, subtract exactly half the patient's accommodative reserve. Now, why just half? Because clinically, if a patient uses more than half their reserve, that ciliary muscle is going to fatigue and they'll get massive astenopia. So let's look at our 4-diopter hyperope with 3 diopters of reserve. They need plus 4 for distance, plus 2.5 for near, minus 1.5 of their own reserve. Boom, their single vision reader is plus 5 diopters. Now for the myope, they need minus 4 for distance, plus 2.5 for near, minus 2 of their own reserve. This leaves a final reading prescription of minus 3.5 diopters. Make sense? Which brings us to Section 3, Bridging the Intermediate Gap. You all know this patient, the 51-year-old engineer who comes in complaining of blurry vision at his computer screens and neck pain from constantly tilting his head back to use his near-ad. A standard bifocal creates this huge blurry gap right at arm's length. So let's orient ourselves to a trifocal lens to solve this. We've got the main distance lens at the top, the near segment at the bottom, and this specific intermediate stripe sandwiched right in between. The major OK Pat pearl here is that this intermediate zone power is exactly half of the near ad segment power. This beautifully gives the patient clear vision in that 67 centimeter to 40 centimeter range, perfectly bridging that pesky computer distance gap. Alternatively, of course, we use PALs, progressive addition lenses. Notice the seamless visual corridor mapping from distance up top all the way down to the full near ad at the bottom. It's this corridor of increasing power smoothly connecting them, which totally eliminates gaps in image jump. But let me give you an attending level clinical pearl right now.
You must always forewarn new presbyopes about the peripheral distortion with these lenses. They are going to experience a swim effect when they turn their head. Remember my golden rule. If you tell a patient about this in advance, it's an expectation. If you tell them after they complain, it's a complication.
All right, Section 4, Image Jump and Prentice's Rule. Time for some physics. Listen, you absolutely, unequivocally must know Prentice's rule inside and out. It dictates that looking away from the optical center of any lens fundamentally induces a prismatic effect. The formula is beautifully simple. PD equals H times D. Prism diopters equals the distance from the optical center multiplied by the dioptric power of the lens. But here is the classic OCACAP trap, so pay attention. H is the distance in centimeters, not millimeters. The boards will literally give you the measurement in millimeters just to trick you. Don't fall for it. And remember, because light rays bend toward the base of a prism, the image the patient sees seems to move toward the apex.
So how does the actual physical shape of that bifocal segment play out clinically? Let's talk about image jump, that sudden, super annoying change in image location when the gaze drops into the ad. Flat top segments minimize jump. Why? Because their optical center sits high up, right at the segment line. When the eye drops into the ad, that H value from our formula is very small, so almost zero prism is induced. On the flip side, round top segments have a low optical center. When the eye drops in, H is large, abruptly inducing significant prism and causing a very jarring image jump.
Now, here is a classic OKAP scenario. You have to distinguish between minus and plus primary lenses. For your myopic patients with minus lenses, flat tops are an incredibly easy choice. They minimize both image jump and overall image displacement. It's a win-win. But hyperopic plus lenses, they force you to make a clinical compromise. You have to ask about their lifestyle. Are they a waiter looking down quickly to check a table? A flat top minimizes jump. Are they an accountant reading a ledger for 4 hours straight? A round top minimizes total displacement while they stay in down gaze. You have to tailor the physics to the actual patient.
Next up, Section 5, Anisometropia and Convergence. This is master-level stuff.
Let's take another Socratic pause here and bring this right into your clinical exam room. Imagine a patient with mixed anisometropia. Let's say a -4 in the right eye and a +4 in the left eye. When they look down to read, Prentice's rule states they're inducing base-down prism in one eye and base-up in the other, right? So how much of this induced vertical prism can the human brain actually tolerate and fuse before the patient starts seeing double? Take a second and think about it.
The answer? Very, very little. Only about 2 to 3 prism diopters vertically. Why is that? Well, human eyes are aligned horizontally, side by side. Evolutionarily, we evolved to fuse massive amounts of horizontal disparity to track prey running across a field, but we have almost zero anatomical need for vertical fusion. Because of this strict 2-diopter vertical limit, our anisometropic patients will severely suffer from vertical diplopia in the reading position unless we step in and fix it.
So what's our solution? The absolute highest yield board answer for this induced vertical phoria is bicentric grinding, specifically a technique known as slab-off. Slab-off literally involves removing lens material from the lower aspect of the lens, and by doing so, you are effectively removing base-down prism. Here is your permanent memory anchor for the boards. Write this down. Slab-off always goes on the more minus lens. Say it with me. Slab-off, more minus. This is hands down the most satisfactory method to save your anisometropic patients from horrible double vision at near.
Now, do not confuse these vertical prismatic effects with horizontal ones. They are totally different beasts. Think about a myope converging their eyes to read. They are looking through the nasal aspect of their minus lenses. This induces base-in prism, which shifts the image temporally. This actually decreases their convergence demand. It makes it easier for them. Hyperopes, however, are looking through the nasal aspect of plus lenses. This induces base-out prism, shifting the image nasally, which forces them to work harder and significantly increases their convergence demand.
All right, home stretch. Section 6, rapid-fire board pearls to lock this all in.
Drill these physics concepts into your mental model right now. The 14-diopter maximum amplitude at age 8. The critical 6 diopters remaining at age 40. Remember that the intermediate stripe of a trifocal is always exactly half the near ad. For anisometropia, slab-off goes on the more minus lens. And always remember that flat-top bifocals minimize image jump because their optical center is sitting up high.
And on the clinical side, you must manage expectations by warning patients about PAL's swim. Also, listen carefully on this one. Never ever switch an elderly fall risk patient who is perfectly used to a lined bifocal into a PAL. the peripheral distortion can literally cause a dangerous fall. You have to take that risk incredibly seriously. Finally, for any OCAP calculation you face, always start with that 40 centimeter default reading distance, which instantly gives you a plus 2.5 diopter demand to work from.
So I'll leave you with this thought to chew on as you review these concepts. We don't just memorize formulas to pass a test. We use them to understand exactly how light bends when it hits the eye. Mastering the why behind the optics and truly understanding how a simple lens induces complex prismatic displacement will make you an absolutely outstanding attending physician who can fix real patient problems, not just a good test taker. Keep reviewing, keep questioning, and I'll see you in the next explainer.